Welcome to Women in Surgery, where we highlight some of the top surgeons at Houston Methodist. All of them just happen to be women. And today we have a special guest, Dr. Aldona Spiegel. Dr. Spiegel, can you introduce yourself?
First of all, thank you so much. This is really a true pleasure and honor to be here. And I'm a plastic reconstructive surgeon. And currently, I'm the chief of the Division of Surgical Innovation here at Houston Methodist.
So there's a lot to talk about. So first of all, you're a plastic surgeon. What does that mean?
So plastic means molding or shaping. And so really my focus is reconstruction, but of course plastic surgery can involve both reconstruction and aesthetic surgery. But my focus is actually breast reconstruction.
So breast reconstruction after surgery for cancer, is that?
Yes, mainly for breast cancer. Sometimes there are some congenital anomalies with breast patients, but the majority of my practice is breast reconstruction after cancer.
So how do you get to being a breast reconstructive surgeon? What is the path?
Whoa, it was a bit of a long path. So I, at the age of 13, decided that I wanted to be a plastic surgeon. Now, at the time, I didn't have anyone in my family who was a physician, but I loved art and I loved to paint. And I also knew I wanted to be a physician. And so at the time, I thought that was a perfect blend and was very logical to be a plastic surgeon. So I focused on that quite a bit. I laser focused, and I was in Canada at the time because originally I was born in Poland. And then my family and I immigrated to Canada when I was 10 years old. My parents left Poland due to, the communist regime. And so we're seeking a better life in Poland. And so from Poland into Canada. And so in Canada, that was really an amazing experience because I learned the resilience of adapting into a new country. And I think that actually helped me in my pursuit of being a plastic surgeon.
So you were 10 years old, you had to learn a new language, right?
Yes.
From Polish to English. How did that go as a 10-year-old?
Thankfully, English is a relatively easy language to learn. And at 10 years old, it really probably took me about 6 months. So that was great. You know, my parents were very focused on the reason why they immigrated is they really wanted to give me a better life. And that was really inspiring for me. I think I learned a lot from that sort of resilience and adaptability. And we were a small family at the time. It was just my parents and I. So we were very close-knit. And then years later, once they settled into Canada, my parents had my little brother, who's actually 17 years younger than I am.
Wow.
But he's also in medicine. He's a cardiovascular anesthesiologist. So he is married to a family physician. His wife is a family physician. They have two little daughters.
So no one was a physician before you, but then you took it and, brought it to the next level. So you dreamt about being a plastic surgeon. And then where did you go to medical school? How did you?
So I fast-tracked into, in Canada, it was possible to fast-track into medical school, so I did. But as I was in medical school, I realized there was an issue because in Canada, there were very, very few plastic surgery residency positions. In fact, there were only 5 at the time in the entire country.
Wow.
However, it was not possible to switch. So if you did not match into plastic surgery, you would essentially be probably doing general surgery for the rest of your life, which at the time for me, that was really not something I could really even fathom. And so I decided to seek other opportunities and decided to come to the land of opportunity and apply to US programs.
Wow, for medical school.
For residency. And so, but being a Canadian graduate and plastic surgery being very competitive, I was really only able to do general surgery. And so my first interview for general surgery programs was actually at Hopkins with Dr. Cameron, who's an amazing man. He's a legend in general surgery. And at the end of the interview, he said, you know what? I'm going to give you a preliminary spot. And that one thing changed my life. He gave me an opportunity, which wasn't easy because as a Canadian grad and as a woman, there were only 3 women out of 30 residents.
Wow.
It was a bit like Survivor because as a preliminary pyramid program, you had to earn your stripes to be able to stay till the next year. And so by the 3rd year, I was actually offered a general surgery categorical position, but I had the opportunity to come to Baylor and do microsurgery. So at the time, the chair of the division of plastic surgery at Baylor was looking for a microsurgery fellow. And
what is microsurgery?
So microsurgery is essentially a way to connect blood vessels using a microscope, usually, or loops, but it's very, very small blood vessels in order to restore blood flow. So essentially, we're able to sort of auto-transplant, take tissue from one part of the body and restore it to another part for reconstruction in the majority. So yes, so that was another opportunity where a mentor was able to see something and say, okay, come down, you will have to do a year, and if you do well, you will get into the residency program.
Wow.
And so again, that was a fantastic, really great opportunity. And so I completed my plastic surgery residency at Baylor.
Fantastic. And so you finished general surgery, a whole residency?
No, 3 years.
3 years. Then you went to plastic surgery. How many years?
So it was 1 year of a microsurgery fellowship and then 3 years of plastic surgery. So all in total, 7 years.
7 years all in total. And then when do you decide that you want to go to breast reconstruction?
So that's another very interesting story. So microsurgery particularly appealed to me because it is a mix of art and very specific technical sort of technique, which really appealed to me. And so I knew I wanted to do microsurgery. And my chair at the time, kind of, I think he knew what he was doing. He invited a very famous innovator who developed a new breast reconstruction procedure. At the time, the majority of autologous or your own tissue reconstruction was using the tram flap, and it was essentially transplanting the lower part of the abdomen to reconstruct the breast microsurgically, but unfortunately was also sacrificing the muscle. Mm-hmm. And this was a newer technique that preserved this. And I still remember sitting there watching his presentation, and it was like a light bulb eureka moment. And I said, this is really what I want to do. The problem is it wasn't really done in Houston. So I had to travel to Europe, to Belgium, where it was starting to be performed, and then also to New Orleans, where Dr. Allen, who was this pioneering surgeon that came and talked about it, was also based. And so I observed for a very short time, and then brazenly, I can't believe that, but I came back to Baylor and started doing this type of reconstruction.
So what is the difference between the old way of doing reconstruction and this way?
So it is a little bit more technically challenging because you're separating the small blood vessels from the muscle. So there was an extra level. It's already a challenging operation because you're transplanting tissue, you're connecting small blood vessels together. They're maybe 2 millimeters at most, so very, very small. And then you're suturing that with a suture that's almost the 10th of a human hair.
Yeah, that's my field, you know.
Yes, you're actually even more. You know, we use 9 suture. You're probably 11. Yes, so we're a little bit larger caliber, but yeah. So the microsurgery part was very interesting, but it wasn't easy, I have to tell you.
So you innovated even more, is that correct? So you took what you learned from your mentor and then you brought it to the next level. How so?
Well, so first I was recruited to stay at Baylor as the first female faculty, which was really exciting. And I think it was really a testament to my chair at the time who mentored me. And he said, you know what, I think we can do this new thing, come in and start doing it. And it was, as I mentioned, you know, being an early adopter of a new procedure isn't easy. There were some critics, there were people that said, why are you doing this? But I really, really believed that preserving that muscle was really important for patients. And so through a lot of grit and time, this procedure is now standard. So everybody sort of ultimately started doing it, and now it's pretty much standard of care.
So now the standard of care is not using a muscle
Correct.
to reconstruct the breast. And you had a part of it. How exciting is that? Where you thought you may enter the field of innovation? How did that come about?
Yeah, so it was always very organic, and it was really mainly to focus on the patient and to help minimize what they go through in their breast reconstruction journey. So, once I started doing this DIEP flap, I realized that we also had another thing that we weren't achieving for patients, and that was restoration of sensation. And again, this was not something that people really thought was important. They thought there was enough sensation that kind of grows in that you don't have to spend the extra time. But during that microsurgical fellowship that I did in between my general surgery and plastic surgery, I did a lot of obstetrical brachial plexus surgery with nerves. And I had one patient come in and basically present 2 years after her reconstruction with a beautiful reconstruction, but she sustained a second-degree burn. She was cooking, some of the water went on her breast, and so she really didn't have the protective sensation necessary.
Oh, wow.
And so she sustained a burn, and that was really another light bulb moment for me to say, wait, we can do something better. So I started connecting the nerves again, early adopter, talking about this in conferences, people looking at me going, oh, I don't know about this. And thankfully now it is a goal that many people want to achieve. It is now becoming standard of care, but that took about 20 years.
Wow, this is fascinating to me. Do you think that the fact that you're a woman played a factor in it, or you can emphasize or really understand what women are going through from the cancer diagnosis, which is life-shattering, and then through this entire process, maintaining the sensation, how important it might be, also the shape and the feeling. Did it play a role, you think?
Yes, I believe that it's extremely important for outcomes to really deliver for the patient what they consider to be the ideal. And a lot of times patients weren't even aware that they would lose sensation. Sometimes that wasn't even discussed. And, when I went to conferences and I would ask before my presentation, who believes breast sensation is important to restore? There were maybe one or two people that would raise their hand, but I would ask the same question when I was giving sort of lectures to patients, just kind of informing them about options for breast reconstruction. Of course, the entire audience would raise their hand. And so as a woman, I think we really want to deliver for women that outcome that they really want to achieve. So I think sensation was definitely a part of that.
So your patients are mainly women?
Yes. I really don't have any. I mean, thankfully, not many male patients are affected with breast cancer, and I work all breast reconstruction and aesthetic procedures are the mainstay of my practice, so the majority of my patients are women.
And now, obviously, there are many more plastic and reconstructive women surgeons. Do you train them? Do you inspire them? How do you get to them?
Yes, that's actually a really big passion of mine because, as I mentioned, when I was going in through residency training, there were very few women mentors. And now, it is amazing how many more women we have. We have the association or the American Society for Reconstructive Microsurgery, and we have a small women's group that was started a few years ago. And at the time, it was only 12% of women. And so I chaired that group. I actually started a wellness program for women that we had the day before our symposium. So it was always nice to connect. And we've grown to 18% now. So definitely not hitting the same mark as other specialties, but we're definitely on a positive.
Wonderful. So I'm glad that you're here, a part of our Houston Methodist surgeons. One of our goals here in this webcast is really to inspire the younger generation. So if anybody is watching, they can take a lesson from your book. I'm very interested in the innovation part. So obviously you talked a little bit about how important it is to kind of take the leap of faith and saying, wait, maybe I'm going to adopt the next procedure, which most surgeons really are reluctant to do, right? Because you're trained in a different technique and you are getting quite good at it. And so changing and learning something new might be challenging. But how about really thinking about a completely different way of doing it and innovating and really moving the entire field forward? In your role, how do you think we can do more of this for our patients and for the younger people that are coming up?
That's a great question. I think one of the important things is really to listen to the patient, because the patients will keep on raising the bar if you listen to them. So, as I mentioned, patients complaining about, lack of sensation was a bar that I felt, okay, we need to do better. The next one was actually implant-based reconstruction, which at the time was not as advanced. We really didn't have great techniques for that. We had some newer materials like acellular dermal matrix, which is a way to sort of hold the implant, create a pocket, and that helped improve our outcomes. So I felt like we were doing really well with our autologous reconstruction patients, but we were not doing great with the implant patients. And so I really wanted to take that on. And again, challenged by patients, kind of, this is okay, but I could see that we had a way to go. And that inspired me actually to develop a design for this acellular dermal matrix, which is kind of collagen that's human derived. And actually, it was, I had experience in sewing. And I made my own prom dress in high school. I loved fashion, didn't have a lot of money for very exciting dresses. So it was a very intricate dress. And that actually, kind of thinking back of a two-dimensional material being made into a three-dimensional sort of corset, was years later what made me think, how can I make this so that women don't have to have a tissue expander? We can do direct to implant reconstruction. And so I designed this for my patients. I didn't really know that it would become patented, it would be used.
So let's stop there and talk about that. I mean, when, design, this is a fascinating story about the prom dress. I can almost imagine you sitting there and sewing, and then years later, you implement it for the benefit of our patients. But how do you get it patented? And then how do you disseminate it? Talk a little bit about that.
It really grew organically. As I mentioned, it was so it's a material that is made by a specific company, and I designed it and sort of shared it with them, and they said, "Oh, this is amazing. Let's patent it." So as you know, we have a patent which is actually owned by Houston Methodist, and it was really at an amazing time because it occurred right before COVID, and it allowed patients to have direct to implant reconstruction without having a tissue expander, which decreased the need to stay overnight. And so many more patients were able to have a mastectomy without sort of a temporizing lumpectomy to have that direct to implant reconstruction. And so all those things culminated together to really allow a patent to be issued for the US and also actually in Australia. So now this is a technique that's used both here in Australia, and what's really great is now I have a preceptorship. So surgeons come here to Houston Methodist. It's actually mainly women, and they learn how to utilize this for their patients and allow a higher number of patients to have direct to implant reconstruction.
Fantastic. How wonderful it is to see, your creation really disseminating around the United States and then the world as well, which is amazing. So tell me a little bit about your role as the Director of Innovation at the Department of Surgery. What do you actually do? I've been in a few of your events and have been very much impressed by what you're doing there. But tell our audience, what you have created here in terms of innovation at the Department of Surgery at Houston Methodist.
So that's a little bit of a story, and I'd love to share that with you because if somebody talked to me 10 years ago and said, this would be your title, I would not really believe them, but it was really an organic growth. And actually, COVID was a part of that. When we had the break from having to do surgery and we had time to think, I had this period of time at home where I came up with all these ideas. And now they have sort of translated into several projects. The biggest one is actually a way to 3D print with a resorbable polymer to allow that polymer to absorb, and as it absorbs, the body to sort of make its own tissue. And as I mentioned, in plastic surgery, we have your own tissue reconstruction, we have implant reconstruction. This is almost a third way to create tissue. And that was an idea that now has been supported by a large grant through our TRI funding here internally. And it's a very exciting day because today we did our first large animal model implantation. So you may see some hat hair and some imprints from my loops because that was what we did earlier
How
today.
exciting. So I'm really impressed by this story because you said, when I had time to think, here is what I came up with. And in our modern world, and I'm thinking about all our physicians, specifically in the Houston Methodist Physician Organization, we don't have time to think. So how might we create that time? Advice from you, maybe advice for me to really implement things here. How might we create those periods of time where you can just think, not do, but think?
I think that's really a great question because we're all busy and it seems like we're getting busier, but I think it's really important to create that time. And for as part of the Houston Methodist innovation role, it actually occurred through support of Dr. Gaber. He really recognized what was happening. It was, I was sort of doing this and he said, you know what, maybe we can do this on a larger scale. Maybe we can have others take some time and really learn a little bit more about innovation. And that actually inspired me to understand how innovation happens, because it's not always the spark and this idea, eureka moment. Oftentimes, and really the way it should be done is you really start with a need and then you solve around that. And so I decided that I really wanted to learn a lot about innovation. And so I decided the best place to do that is Stanford, where they have a very well-known biodesign program. And so for 6 months, I did a training to become a faculty of Stanford
Amazing.
Biodesign. And that allowed me to really understand that framework and to bring it back here.
So tell us in a nutshell, what is that framework? Just so, if somebody is, because we are trying to really replicate that program and bring it to Houston Methodist. So what is that framework? You said it's not a eureka moment where you think about it in the shower and then start. There is a framework. Yeah. What is it?
So oftentimes, and especially as surgeons, we're sort of trained to look for solutions. You have a solution, you have an implementation of that solution, but best innovation happens when you first think of the need. And when you can craft the need into one that you feel like that's most impactful. And then once you do that, that's when you start from scratch and you think about all the solutions, even wacky solutions that are possible. And then you filter those down again. And that's really the basis of the biodesign process. And so we had our first biodesign program, as you know, last December, and it was really energizing. I think it was the first time where we really had an innovation program, and it brought together physicians and researchers and engineers that we have such a rich framework to at Houston Methodist, and that was really exciting.
Yeah, so it goes back to your story about the sensation of who might be the best person to see what the need is. It's really the patient, and who is listening to the patient? It's really the physicians. So we believe, I think we share that belief, that a physician can be an innovator if we support them to do so and if we train them to do so. It doesn't happen without a lot of support. Tell me a little bit about your new adventure in MIT.
So, yes, I would so I guess when I start talking about MIT, I have to say a little bit about my family. So I have 3 children, and I have my college child, who's my oldest son, and he's actually at MIT. And then I have 2 kids in high school, and I'm just so privileged. They're all such wonderful kids. And when my son was accepted to MIT, I never would have thought that a year later I would decide to pursue an entrepreneurship business side. I really, just like I wanted to understand the innovation framework at Stanford, I felt that MIT was really the mecca of a place that you can understand design and device innovation from an entrepreneurial perspective. So a year after my son started, I became a part of the Sloan School of Management, and I am in the middle, currently actually right smack in the middle of my MBA. So it is an in-person program, so I travel and I get to see him as well when I travel, so it's been amazing.
Yeah, so to all the kids of all the physicians who might be watching us, you may influence your parents as well. That's a fantastic story. So Dr. Spiegel, it seems like you went through a path that nobody can follow. Any advice for our listeners? What they can take, it's obviously nobody can really backtrack your footsteps all the way from Poland to Canada to the United States to Johns Hopkins to Houston to MIT, Stanford. You cannot replicate that. But what have you learned, and any words of advice specifically for women?
Yes, I think one important thing to think about, a lot of women are sort of struggling with work-life balance. It's a big question that I get a lot. How do you balance it all? Well, the truth is there is no balance. I think of
You're
it.
breaking my heart. Okay.
No, but I think about it. Imagine somebody walking on a tightrope. From the observer, they seem to be very balanced. But the vantage point of the person on the tightrope, they're always just making sure they don't fall off. And I think once you have that perspective, it's much easier than if you think you're supposed to be in balance. And I think for women, it's just a matter of prioritization. And I tell women, you have to think about it sort of, you're juggling a lot of balls, and you have, work, you have your professional career, you have so many other things, and you have your family. And that one is unlike the others which ones you can drop. The family one is the one that's made of glass.
Yeah.
You should never drop that one. And so if you think about it that way, I think it is possible to be a surgeon. It is possible to have a family as a female at the same time. Of course, it's a partnership. It's amazing. I have a very supportive husband who has more flexibility. He's an entrepreneur. So it's always been really great to be able to focus on what I'm doing, knowing that he's there for the kids. But I do have some mom guilt for sure. But
Me too.
But my son told me once, I kind of told him I couldn't go to an event, and I felt quite bad about that. And he said, Mom, it's not about the quantity, it's really the quality of time that we spend together. And so that really was very nice.
Yes, and another thing I'm hearing very loud and clear in your story, it's a story of evolution. So you don't have to do everything right now, and there are phases. Even in your story, there were phases that you developed to be who you are today. So, all the people that are watching and thinking that they have to do it all right now, then you can do it all, but one phase at a time.
Yes, I think that's really important. It's a long game. It's not a short game. And sometimes there may be failure. And really, failure is extremely important to learn. As I mentioned, I think that my experience of being an immigrant really allowed me to gain grit and ability to weather some storms that, weren't easy as a female in surgery. Now, it's actually a funny thing. I recall back 25 years ago when I was packing for conferences, I was packing pantsuits. I wanted to be sort of one of the guys. I wanted to fit in. And it's so amazing now when I go to conferences, I have dresses, and some of my, younger colleagues have mini dresses. resources, and there is really, so it's just even in that.
But this is plastic surgery.
Yes, 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 that is true. So it's been an amazing evolution, and but I do. So I want to inspire women to say, don't think this is, it's not easy, but it's definitely possible.
Fantastic. Well, I think also the world is changing around us. I think we had a little conversation before about all the AI and other technologies that are coming our way. Do you think that that will actually balance the field, in terms of male, female, kind of help everybody bring the level up? What do you think?
I think AI is amazing because it allows sort of to self-augment yourself. And I think women are just naturally born multitaskers. We just have to do a lot. And so if you have a tool that helps you maximize your time, and I think it's going to be amazing.
Yeah, I think one thing that you mentioned, and I completely agree, is that, the time to spend with your family is priceless. And so how might we think about it while we are, on a career path that is very demanding? So how might we do it all, but really remembering that there are people at home who really need us, and nobody can really replace that role. So it seems to me that, if anybody is having any troubles, they should call you. You have it figured out. Thank you so much for being here for this conversation. Thank you for everything that you're doing. And most importantly, thank you for being the role model of physician innovator at Houston Methodist. We appreciate you.
It's a true honor. Thank you so much.
And thank you for watching another episode of Women in Surgery.